want to begin with a question. Picture two people entering a clinic. Both are lucid. Neither is delusional or confused about physical reality. Both describe calmly and consistently a profound mismatch between the body they have and the body they experience as properly their own. They have lived with that mismatch for years, often since childhood, and they are asking medicine for a significant and irreversible operation to bring the body into closer alignment with the self. The first person is describing gender dysphoria. The second is describing body integrity dysphoria. They want a healthy limb removed. Then I ask the room what happens next. For the first person, medicine has developed clinics, specialists, professional association, standards of care, and, in many countries, public or insurance-funded treatment. For the second, medicine has produced a diagnostic code and little else, a comparable structure of suffering, a comparable logic of request, a radically different clinical response. Why? Which difference justifies that asymmetry, and does it survive careful scrutiny? When I began comparing these two conditions, I expected medicine's different response to rest on a clear ethical distinction. Perhaps the difference would lie in decision-making capacity, the level of harm, the evidence for benefit, the risks of surgery, or the nature of the bodily change being requested. The closer I examined those distinctions, the less decisive they became. Each explained part of the difference, but none settled the comparison on its own. That unresolved question is the subject of this episode. This is Contested Bodies. I'm Leandro Loriga. Welcome to episode 4, BID and Gender Dysphoria, a productive comparison. Previously, we followed how the condition moved through several medical interpretations, from sexual deviance to psychological disturbance to identity and eventually to a possible disorder of bodily representation. We also saw how BID gained official recognition in ICD-11 while remaining clinically unresolved. Episode 3 examined the main explanations: body mapping, mental imagery, embodiment, and the social construction of the self. This episode turns towards medicine's response. Why has gender dysphoria developed clinics, specialists, professional guidance, and recognized treatment pathways, while BID has received a diagnostic code and very little else? My own research began with a related question. Under what conditions could it be reasonable for a doctor to agree to the requested amputation of a healthy limb? That question led directly to the comparison with gender dysphoria. Medicine already accepts within gender-related care that significant bodily modification can sometimes relieve persistent distress caused by a mismatch between body and self. BID presents a structurally comparable request. The comparison is not an equation between the two conditions. It is a test of consistency. We need to identify what they share, where they differ, and whether those differences are ethically strong enough to justify their radically different clinical treatment. That is what I mean by a productive comparison. It helps us examine the assumption behind recognition, legitimacy, autonomy, and access to care. To build that comparison properly, we need to begin with a word that appears everywhere in this debate and is rarely defined clearly: identity. Identity is one of those words that appears everywhere and becomes harder to define the longer you look at it. Before comparing two conditions in which identity plays a central role, I need to explain how I am using the term. Rogers Brubaker is an American sociologist known for his work on ethnicity, nationalism, and social categories. Frederick Cooper is an American historian whose research focuses on colonialism, citizenship, and political belonging. In a widely discussed article, they distinguish between identity as a category of practice and identity as a category of analysis. A category of practice is a word people use in everyday life. They claim an identity, defend it, organize around it, and use it to ask for recognition. It can become the basis of solidarity, community, and political action. Someone may identify as disabled, religious, national, ethnic, or part of a cultural group. From the inside, this identity is experienced as immediate and consequential. It shapes how the person understands themselves and how they expect others to treat them. A category of analysis is different. Here, researchers use identity as a tool for examining how people form groups, understand themselves, draw boundaries, and make claims about belonging. The difficulty is that academics often stretch the word too far. Identity becomes fluid, constructed, negotiated, performed, imposed, inherited, and chosen all at once. Eventually, it risks explaining everything and therefore explaining very little. There is identity as people live it, and there is identity as researchers try to explain it. There is a trap here. Treat identity as entirely natural, fixed and beyond question, and it becomes impossible to examine. The person's account is accepted as self-evidently true, with no room for interpretation or analysis. Treat identity as nothing more than a social construction, and another problem appears. The person in front of you experiences that identity as immediate, continuous, and deeply their own. Academic language about fluidity and negotiation can fail to capture that lived certainty. For this episode, I will use identity in a modest and practical sense. Identity is the feeling of continuity over time. It is the sense that I remain one person across different moments and roles. The person I was yesterday, the person I am today, and the person I expect to become tomorrow all belong to the same unfolding story. That continuity develops through relationships. George Herbert Mead was an American philosopher and social psychologist who studied how the self emerges through language, interaction, and shared social life. He argued that we become aware of ourselves partly by learning to see ourselves from the perspective of other people. We move through different roles and situations without losing the thread that connects them. We may be a colleague, a parent, a patient, a friend, or a stranger, while still experiencing ourselves as one person. Part of that unity is assembled through the eyes of others. The body sits at the center of this process because it is both lived from within and read from outside. It is the most visible part of the self and the part through which other people first recognize, classify, and respond to us. When the body seen by others and the self-experience from within fall out of alignment, the rupture can become profound. In some cases, that rupture takes the form of dysphoria. Let me state the shared premise clearly. Gender dysphoria and body integrity dysphoria can both involve a persistent gap between the physical body and the body experienced as consistent with the self. That gap can produce dysphoria, sustained distress, unease, or a sense that one's bodily configuration is profoundly wrong. Precision is important here. A person with gender dysphoria generally understands their anatomy. A person with BID knows that the limb is present, healthy, and functional. Their experience is usually not based on delusion or confusion about physical reality. Michael First's research, which we discussed in episode 1, found that people with BID understood perfectly well that the unwanted limb existed and worked. The conflict lies between two forms of experience: the body as it physically exists, and the body the person experiences as properly their own. I have described BID as a form of non-delusional somatic alienation. Somatic means bodily. The person feels alienated from part of their own body while remaining fully aware of its physical presence. Comparable language appears in discussion of gender dysphoria. The differences still need to be examined. The most striking difference lies in history. Gender dysphoria enters the clinic carrying decades of research, activism, theoretical development, diagnostic revision, professional guidance, and clinical experience. BID enters with far less behind it. It has an ICD-11 diagnosis, a limited research literature, some neurological evidence, a developing ethical debate, and a small number of reported surgical cases. It also carries considerable discomfort. This difference in intellectual and institutional history shapes medical judgment more than is usually acknowledged. Gender dysphoria has had time to become understandable to medicine. BID has only recently become officially visible. So, we need to examine the history that gave one condition clinical legitimacy while leaving the other at the edge of practice. It is also a history of medicine revising its own categories. For much of the 20th century, psychology and medicine often treated biological sex, social behavior, gender role, and identity as parts of one expected package. A boy was expected to behave in recognizably masculine ways. A girl was expected to behave in recognizably feminine ways. Conforming behavior was taken as evidence of healthy development. Crossing those boundaries could be interpreted as confusion, deviance, or a sign that something had gone wrong. Researchers used terms such as sex typing and cross-sex typing. Sex typing meant learning and displaying the behavior considered appropriate for one's sex. Cross-sex typing described interests, traits, or behavior associated with the other sex. Jerome Kagan was an American developmental psychologist who studied childhood, temperament, and the formation of social behavior. Writing during the 1960s and 1970s, he reflected a period in which strong departures from expected gender behavior were often treated as developmental problems. That framework gradually began to change. Researchers started separating concepts that had previously been bundled together. Sex referred mainly to bodily characteristics. Gender referred to social roles, expectation, identity, and behavior. Once these elements were separated, variation became easier to describe without automatically classifying it as pathology. Sandra Bem played an important role in that shift. Bem was an American psychologist whose research challenged the assumption that psychological health required people to fit neatly into masculine or feminine roles. In the 1970s, she developed the idea of psychological androgyny. A person could combine traits culturally labeled masculine and feminine, such as assertiveness and tenderness, without being confused or maladjusted. Flexibility across gender roles could be adaptive. That changed the direction of the discussion. Gender development came to be understood through several interacting dimensions: how people experience themselves, how strongly gender shapes their identity, which social expectations they absorb, and how much pressure they feel to conform. Medicine and psychology were beginning to loosen the old equation between anatomy, behavior, social role, and identity. That change created the conceptual space in which gender variance could later be understood through incongruence, distress, and care rather than through deviance alone. Here, the shift moved beyond academic theory and began to reshape medicine itself. The clearest example is homosexuality. The American Psychiatric Association, the professional body responsible for publishing the DSM, removed homosexuality from its list of mental disorders in 1973. Its wider membership confirmed the decision the following year. The remaining diagnosis linked to homosexuality disappeared from the DSM in 1987. The World Health Organization later removed homosexuality from the International Classification of Diseases in 1990. A way of living that medicine had classified as pathology came to be recognized as part of ordinary human variation. The people had not suddenly changed. Medicine had changed its judgment. It revised the boundary between illness and variation, between disorder and a legitimate form of human life. That history showed that diagnostic categories involving sexuality and identity could be reconsidered. They were shaped through evidence, professional debate, activism, cultural change, and institutional decision-making. The clinical recognition of gender dysphoria developed within this broader history of revision. Over time, the language moved away from deviance and disordered identity towards incongruence, distress, recognition, and care. Gender dysphoria therefore entered the contemporary medicine with decades of theoretical argument, political struggle, clinical experience, and institutional development behind it. Now, place BID beside that history. BID has had very little comparable development. It has no long tradition of theoretical elaboration, no broad movement challenging its pathologization, no widespread public debate about what counts as a legitimate bodily identity, and no clinical infrastructure comparable to that surrounding gender dysphoria. It entered ICD-11 and was given a diagnostic code. Then it was largely left standing in the waiting room. Before turning to the ethics, we need one more layer: narrative. The patient's story. With a broken bone, an infection, or a tumor, medicine can often point to an X-ray, a blood test, or a visible lesion. Dysphoria rarely offers that kind of evidence. The clinician therefore depends heavily on what the patient reports. How long has the experience been present? When did it begin? How stable has it been? What does the person feel towards their body? How do they understand themselves? What do they believe would relieve the distress? In conditions such as BD and gender dysphoria, the story is part of the clinical picture. It tells the doctor how the person experiences the body, how the distress developed, and how that experience fits into the wider continuity of their life. People use stories to restore continuity after their sense of self has been unsettled. A person may feel that their life has stopped making sense. Through narrative, they connect the past with the present. They identify a beginning, explain the suffering, and imagine a future in which the conflict might be resolved. For someone living with dysphoria, telling a coherent story can therefore become part of rebuilding a coherent self. The story does more than describe the experience. It helps organize it. Narrative also has risks. A coherent story can help a person make sense of suffering. The same search for coherence can also simplify, reshape, or over-organize an experience whose origins remain uncertain. The mind looks for patterns. It looks for a beginning, a cause, and a direction. When an experience is disruptive and difficult to explain, memory and interpretation may gradually assemble a story around it. Persecutory delusions show an extreme version of this process. A person links unrelated events into a coherent account of threat or persecution. BAD is not a delusion. The comparison concerns the way human beings use narrative to organize experiences that otherwise feel chaotic. A patient's account is therefore indispensable, but it is not a perfect recording. It is shaped by memory, suffering, expectation, available language, and the need to make sense of oneself. The clinician cannot accept it uncritically. They also cannot dismiss it because it lacks laboratory confirmation. The difficulty lies in listening seriously while recognizing that every story has already been interpreted by the person telling it. Power enters the encounter at this point. Doctor and patient are negotiating the meaning of the same experience. The doctor may frame it as,
"This is a fetish, this is confusion, this is self-harm. This desire does not express who you truly are."
The patient may offer another account.
"This is my proper body. I have felt this way for as long as I can remember. This is the only way I can become whole."
One interpretation eventually carries greater authority. That interpretation shapes the diagnosis, the treatment offered, the referrals made, and whether the request enters medicine as legitimate care or remains outside the door. The story accepted as authentic becomes the story through which access is granted. That brings us to authenticity. We usually think of autonomy as a capacity belonging to the person. Can they understand the relevant information? Can they appreciate the consequences? Can they compare the available options? Can they communicate a stable choice? Tom Beauchamp and James Childress, two American bioethicists whose work helped establish the 4 principles approach to medical ethics, place respect for autonomy among the central duties of clinical practice. Under this familiar account, a competent adult should be able to make their own medical decisions, including decisions a doctor considers unwise. At the margins of medicine, however, autonomy often depends on another judgment. Is the request authentic? By authentic, I mean that medicine accepts the desire as a genuine expression of the person and recognizes the condition behind it as clinically legitimate. Diagnostic recognition gives doctors a language through which to understand the request. Once that recognition exists, a path opens. The patient can receive a diagnosis, find a specialist, enter an established pathway, and ask for intervention that medicine already knows how to consider. When the condition lacks that institutional background, the request is more easily treated as strange, suspicious, or disconnected from the person's proper self. The patient may still understand the risks. Their reasoning may remain coherent, their choice may have been stable for decades, yet their autonomy becomes fragile because medicine doubts the authenticity of the intention itself. I have come to see authenticity as a gatekeeper. Recognition allows the request to appear legitimate. Legitimacy allows the patient's autonomy to be taken seriously, and autonomy becomes the route through which access to treatment is granted. Autonomy is assessed through the person's ability to understand, reason, and choose. In practice, it is also filtered through recognition. A lucid and competent adult may be treated as autonomous when requesting an intervention medicine already recognizes. Present the same level of understanding in support of an unfamiliar request, and suspicion enters the room. The patient's capacities have not changed. Gender dysphoria has passed through decades of research, argument, activism, diagnostic revision, and clinical development. Medicine has learned how to name it, assess it, and place it within recognized pathways. That history gave the condition a legitimacy and gave clinicians a framework through which consent could be understood. BID stands much earlier in that process. The BID patient may understand the risks, the permanence of amputation, the rehabilitation, and the consequences for daily life. Their desire may have remained stable for decades. Still, medicine may question whether that desire expresses their authentic self. I find this unsettling. At the margins of practice, autonomy appears partly dependent on whether medical authority already recognizes the intention as legitimate. The clash between authority and autonomy therefore enters the assessment itself. Medicine is not only asking whether the patient can choose, it is also deciding whether the choice deserves to count as an autonomous one. I have described this as autonomy being judged through the intention rather than through the person. We will examine that problem directly later in the season. For now, it gives us the foundation for the justice argument. We now have the pieces of the comparison. Both conditions can involve persistent bodily incongruence, serious distress, early onset, and an intact understanding of physical reality. We have also seen how authenticity can connect recognition with legitimacy, autonomy, and access. Now we can ask the ethical question through the principle of justice. Treat similar cases similarly. Different treatment requires an ethically relevant reason. So let us compare the two. Both can involve dysphoria arising from a mismatch between the physical body and the experienced self. In both, the person usually understands their anatomy and remains in contact with reality. Both can cause profound and persistent distress. Both have been associated with self-harm when suffering remains unresolved, although the evidence is broader and more developed in the gender dysphoria literature. And in both, the requested intervention changes the body in an attempt to relieve dysphoria. Medicine has developed recognized pathways for gender dysphoria. Depending on the country, these may include specialist clinics, professional standards, psychological support, hormonal treatment, surgery, and public or insurance funding. For BID, requested amputation remains almost universally refused. Justice therefore asks which ethically relevant difference justifies this radically different response. Here is where I land. Provided BID is accepted as a genuine medical condition, I have found no significant ethically relevant difference that clearly justifies excluding amputation from consideration while accepting bodily modification for gender dysphoria. Several objections are commonly raised. The first is that BID amputation would be cosmetic, an operation performed on a healthy body to satisfy a personal preference. I do not think that description fits. The request arises from persistent dysphoria and serious distress. Similar objections have also been directed at gender-affirming surgery. Medicine has learned in that context that bodily form can have profound consequences for identity, psychological well-being, and the ability to live an ordinary life. The second objection concerns resources. A planned amputation, rehabilitation, prosthetic care, and long-term support would cost money that could be spent elsewhere. That concern is legitimate, but it cannot be applied selectively. Health systems already fund intervention intended to relieve severe psychological suffering, prevent later harm, and improve quality of life. Resource allocation may affect whether treatment is available, yet it does not establish a moral difference between BID and gender dysphoria. The third objection is the slippery slope. If medicine permits one healthy limb to be removed, where would it stop? Would every request for bodily alteration then have to be accepted? That concern points towards the need for careful criteria, assessment, and boundaries. It does not establish that BID and gender dysphoria differ in an ethically decisive way. The candidate differences therefore tend to weaken under scrutiny. Some fail to describe BID accurately. Others also apply to forms of bodily modification that medicine already permits. None, so far, clearly explains the asymmetry. The argument is about consistency. I am not calling for hospitals to begin amputating healthy limbs on request. I am asking medicine to explain its reasoning. ICD-11 recognizes BID as a medical condition. Once that recognition is granted, the request for amputation cannot be dismissed as self-evidently illegitimate. Medicine must identify the ethically relevant difference that justifies excluding the intervention from serious consideration. I have not found a difference that fully carries that burden. BID and gender dysphoria remain distinct conditions. Their lived experiences differ. None has yet been shown to justify the complete acceptance of bodily modification in one condition and its near total exclusion in the other, once both are recognized as serious forms of persistent dysphoria. Medicine may eventually identify such a distinction. Until then, the asymmetry remains ethically unresolved. We began with two people describing a comparable form of bodily incongruence and asking medicine for an irreversible intervention. Medicine responds to them very differently. Part of the difference lies in recognition. Narrative also shapes the response. Medicine must decide which account of the body it accepts as authentic, and that judgment influences whether the patient's autonomy is respected in practice. I have come to see authenticity as a kind of currency. Recognition gives a condition legitimacy. Legitimacy strengthens the patient's claim to autonomy, and autonomy opens access to treatment. Beneath all of this remains the question of justice. Next time on Contested Bodies, we leave comparison behind and enter the operating theater. Episode 5 examines the ethics of body-modifying surgery. Medicine already permits major intervention on healthy bodies. Cosmetic surgery alters healthy anatomy. Gender-affirming surgery may involve irreversible transformation. Living organ donation removes healthy tissue from one person for the benefit of another. The fact that a body part is healthy cannot settle the ethical question by itself. So, where should medicine draw the line? When does bodily alteration count as treatment? When does it become harm? And what makes consent strong enough to justify an irreversible operation? That is where we go next. Episode 5, Cutting and Consenting. I'm Leandro Loriga. This has been Contested Bodies. Thank you for listening. I'll see you next time. If you enjoyed this episode, please share it and follow Contested Bodies wherever you listen. Contested Bodies is independently written, produced and hosted by me, Leandro Loriga. The podcast receives no institutional funding or external financial support. This initiative was born from a desire to make invisible lives visible and examine the gray zones of medicine and the human condition. You can support the research, production, and future episodes through the donation link in the description. I'm Leandro Loriga. This has been Contested Bodies. Thank you for listening. I'll see you next time.